So, first of all, quality of ECG. 10 millimeters wave. Can you see?
But some bright flash.
P waves are present everywhere. Regularity of rhythm.
Sinus.
Rhythm is irregular.
Regular.
Sinus, but irregular. There is arrhythmia. Next, electrical axis of the heart. This R wave and this R wave are practically equal, so it is shift to the left or horizontal electric axis of the heart. Next, assessment of each wave, segment, and interval, and also heart rate. Heart rate is 33 beats per minute, 53 beats per minute in different places.
Sir, I have a question like if
Segments and intervals. T wave is negative. T wave is negative. Next lead. Q wave, it's pathological, it's equal to R wave. It is third lead. If there are changes in the second and third lead, always look at AVF. AVF does not have two waves. AVL, T is negative, ST segment may be a little bit depressed.
so what we have in the AVF.
Second, third, and AVF are inferior wall. That's why if changes are in the second and third, look at AVF.
Yeah, but here
If you,
is
chest leads. Small R wave, very big.
It's R.
R is positive wave. Small R wave, big
Q.
S wave.
is
S. Q wave is before R.
before
If
S wave.
wave is after R wave, it is S
S
wave.
wave.
So very big S wave.
and ST.
ST segment is elevated. T is bigger than R wave. So T is big one. Same thing. Same. This place, they are equal.
ST is
ST is normal. ST is normal, T is negative. T is negative, R waves may be a little bit big. So, if patient come to us with a chest pain, it is ischemia. But also, because of R wave is small, S wave is big, and big R waves are here, it can be hypertrophy of the left ventricle, and there is levogram here. So, if there are no clinical signs of ischemia, ischemic changes in the ECG in the hypertrophy of ventricle are possible. So negative,
So
yeah.
you said hypertrophy because of this graph.
Because of S wave is big, R wave is small here, and R waves are big here.
And you said levogram because
Levogram because of electrical axis shifted to the left. So, patient can have two problems: hypertrophy plus ischemia. So, let's
hypertrophy or ventricular hypertrophy. How to read?
ventricular because of QRS complex is changed. About ischemia, it's better to do troponine test. If troponine test is positive, it's myocardial infarction initial stage. If troponine test is negative, these signs can be due to ischemia, due to hypertrophy of the left ventricle. So these changes are possible in hypertrophy. Remember about it. Also, to confirm is a hypertrophy or not, we can use criterion, sum of R wave in the V5 or V6 plus S wave in the V1 in millimeters. I do not have scale and cells are invisible. If this one plus this one is more than 35 millimeters,
35 millimeters, like more than 3.5. 3.5. Box.
3.5 centimeters. Yeah. So it is hypertrophy of the left ventricle.
Like each box 10 millimeters. So it's
Big box is 5 millimeters.
5 millimeters. So okay, there's more 6 boxes.
Yeah. So we need to confirm it. If somebody have a scale, we can measure. So this size is 10, 11, millimeters, and this one is
This is centimeter.
16. 16 plus 11 is 27. So it's not hypertrophy. So these changes are ischemia. So if it is ischemia,
And some V1 and what do you call
V1 S wave and V5 or V6 R wave.
Okay, V1 or V6.
So we confirm that it is not hypertrophy. That's why it is ischemia. If there is no hypertrophy, ischemia cannot be alone. So ischemia can be due to initial stage of myocardial infarction. Ischemia can be due to angina pectoris. To differentiate, we need to prescribe troponine test. Before results of troponine test, diagnosis is acute coronary syndrome with ST segment elevation. About this Q wave. This Q wave is alone, without ST segment changes and T wave elevation or negative T wave. Patient had myocardial infarction previously. This Q wave is marker of previous myocardial infarction. Third lead,
It's not acute.
because of there is only Q wave changes. In acute stage, there is elevation of ST. Acute phase is necrosis plus ischemia. Ischemia is ST and T. Necrosis is Q wave. Subacute stage is only negative T plus Q wave. In our case, there is only Q wave. Look at the blackboard. Fourth stage, macrofocal myocardial infarction. So, same picture. That's why it is previous myocardial infarction. It is post-infarction cardiosclerosis. And arrhythmia is sinus one because of P waves are present everywhere. This cardio is complex enough. First step of ECG assessment is what is first stage? Quality. Is quality okay?
No.
5 millimeters. So can we continue assessment of the curve? No.
Rejects.
Rejected.
Somebody took my cards yesterday and shaked them. Quality is okay.
Yeah.
P waves are here. Rhythm is sinus. Distances are similar. Rhythm is regular. Electrical axis of the heart. The register wave in the second lead. It is normal electrical axis of the heart. 5, about 4 millimeters. This one is 3 millimeters. So this one is the biggest.
Doctor, what's that? Some. What's that?
Left hand is
Yeah.
first lead.
Uh-huh.
Right hand is third lead. The biggest wave in the middle. Electrical axis of the heart is normal. If the biggest would be in the left hand, it is left shift. If the biggest would be in the right hand, it is right shift. Segments and intervals. Heart rate. There is tachycardia. Because of either electric line is too short. Diastole is too short. We need to count it to confirm, but I'm sure there is tachycardia.
R into this 3.
15 millimeters plus 2 plus 1, so 13 millimeters, 18 millimeters. Speed of tape is 25. How to count heart rate?
25, 60 over RR interval into the 25.
Let's count.
Maybe
There is calculator.
98.
There is calculator.
Divided by RR.
Okay.
18. yeah?
90
into 25.
96. So 98. 83.
இங்க கீழே எத்தனை இருந்தது 18
18 multiple. Have you counted like this?
Yeah.
So there is no tachycardia.
83
Nice. So there is no tachycardia, but distance is short. Tachycardia was possible. Next, changes of wave segments and intervals in each lead. Lead number 1. ST segment is elevated. It's above isoelectric line.
Ischemic.
Second lead, T wave, in size like a R wave. It's big. Third lead, ST segment below isoelectric line. There are changes in the second and third. AVF, ST segment below isoelectric line.
So for the isoelectric reference, use to took only PQ
We take this
segment, right?
this distance. PQ segment is not always visible. We take diastole and do the straight line between diastole. Next, AVL, elevation of ST. Forget about AVR. V1, P. Is it R or not R? It's not clear, but I would say that it is not R. And next wave is Q, S wave. R is absent. V2, Q, S wave, elevation of ST, big T. V3, Q, S, elevation of ST, big T. V4, R wave, elevation of ST, big T. Big T, elevation of ST. So, which changes do we have? What are changes the most serious? This one. This changes. Look at blackboard. What is stage and size? Which picture? There are no R waves. That's why it is transmural. ST segment is elevated and there is Q wave. That's why it is acute. So it is acute transmural myocardial infarction. Next location. First, second lead have changes. V1, V2, it is anterior wall. V3 is septum. V4, V5, apex and partially lateral wall. V6 is not involved. So in these leads there is myocardial infarction. Anterior wall, septum, apex, partially lateral wall.
So myocardial infarction.
So first of all, quality. Look at speed of tape, 50 millimeters per second. Because of we expect cardiovascular system pathology. Quality is okay. P waves are here. Distances 53, 52 millimeters are practically equal.
Yeah. Okay.
So rhythm is regular. Next, electrical axis of the heart shifted to the left.
Left.
R wave, and R wave. The biggest one is in the first lead. Next, assessment of waves, segments, and intervals. There is Q wave. It's not pathological yet because of it's less than fourth part of R wave. Second lead, there is Q wave. It's like a R wave in the size, so it is pathological. ST segment is normal, T is normal. Third lead, Q wave, R wave, S wave, so it is pathological Q wave. ST segment and T waves are normal. Second and third have changes, that's why I look at AVF. Q wave, ST segment is normal, T is normal. So second, third and AVF have pathological Q waves. Pathological Q waves without ST segment and T wave changes are signs of post-infarction cardiosclerosis or reduction stage, depending on period when patient have got these changes first time. So it is post-infarction cardiosclerosis after big focal because of R waves are present in all these three leads. There are Q waves plus R waves. That's why it is macrofocal myocardial infarction. If R wave disappear, it is transmural. And wall. Second, third, and AVF is inferior wall or diaphragmal wall. Patient have got myocardial infarction in the inferior wall of the heart. But there are chest leads also. V1, P, maybe R or maybe not R, it's not clear. This wave is very deep S wave or QS wave. ST segment is close to isoelectric line. V2, QS wave, ST segment is elevated. QS wave, ST segment is above isoelectric line 2. Same, Q wave, small r wave, ST segment is normal. So in this leads, ST segment is not above isoelectric line.
50 mm. So, with
So there is Q wave, there are no R waves. If R wave absent even in one lead, it is transmural one. There are no R waves and there is elevation of ST segment. So it is acute myocardial infarction, acute transmural myocardial infarction. But maybe this ST segment starts to go downward. We need to assess it in the dynamic. If previous card was with a high ST segment, it can be a beginning of the subacute stage. And walls which are affected. V1, V2 is anterior wall, V3 is septum, V4 is apex, V5, V6 is lateral wall. Total myocardial infarction. All walls are affected. So patient had old myocardial infarction plus new one. I need to put myocardial infarctions in another place. So this card is not about myocardial infarction. Quality is okay. P waves are here. Electrical axis in the middle. Rhythm is regular or not, it's not clear because there are only two complexes.
So then how can we conclude this is regular?
It's part of real card. In real card we need to register at least 3-4 complexes.
Okay.
Assessment of the segments and intervals. Equidistance is long. It is topic of our future lesson. V1, V2 have got small R waves, big S. V5, V6 have a big R waves. We need to count sum, the biggest S wave plus the biggest R wave. If it is 35 millimeters and more, it is hypertrophy of the left ventricle.
So
It will not be here. 20, 30, 35. It's equal to 35, maybe 36 millimeters. So we can confirm hypertrophy of the left ventricle. And zone in which R equal to S wave. R is here, S is absent. R is here, S is small. R is bigger than S wave. V3, R is smaller than S wave. R equal to S somewhere between V3 and V4. If we will move electrode a little, we will find the zone. So between V3 and V4. It can be additional criterion of the left ventricle hypertrophy. Quality. P waves are here. Rhythm is regular. Maybe tachycardia is here, we need to count. Electrical axis of the heart. This one is bigger than this one, but this one is bigger than this one too. So electrical axis is not clear. It's not clear because of myocardial infarction. Second lead, there is Q wave. Third lead, Q wave, AVF, Q wave. ST segments are normal. T wave is absent. It is reduction stage of myocardial infarction. Second, third, and AVF are inferior wall. R waves are here. Myocardial infarction is macrofocal. V1, Q, S wave, elevation of ST. V2, R wave. Next is S wave, elevation of ST, doublet, T, biphasic T. R wave, S, elevation of ST, doublet, T. Elevation, elevation, elevation. So, because the R wave is absent here, it is transmural myocardial infarction. QS plus elevation of ST. It is acute phase. Acute transmural myocardial infarction in the anterior wall, septum, apex, and lateral wall. All leads which are changed. plus old myocardial infarction in the inferior wall. Let's check this card. Electrical axis of the heart may be normal.
Yes, yes.
14. Yeah, it's normal. This one is the biggest. Rhythm is regular, rhythm is sinus, but look at these leads. V1, V2 have a big S wave, V5, V6 have a big R waves. The biggest S wave is here. It's 15 millimeters. R wave is here. 1, 2, 3, plus 2 and plus 3 more, 20. 20 plus 15 is 35. So it is left ventricle hypertrophy. And look at this lead. S equal to R. Normally it should be in the V4. So this zone move higher to V1, V2. Currently it's in the V2. One more criterion. There is no shift of electrical axis of the heart, but there are this criteria. R equal to S in higher leads. V6 have a big R waves, V1, V2 have a deeper S waves. Sum of R and S is more than 35 millimeters. Quality. Electrical axis of the heart, the biggest R wave in the third lead. Next. Negative T, negative T, negative T, V1, depressed ST segment and negative T, V2 same, negative T,
T negative in the V1, it's normal. Right?
T should be positive in the V1, T should be positive everywhere. So, and depression of ST is not possible in normal case. And also there are big S waves in V5, V6, big R waves in V1, V2. And in the V5, V6, R equal to S. So it is hypertrophy of the right ventricle, and ischemia is due to hypertrophy of the ventricle. Sum of R wave plus S wave for right ventricle should be more than 10 millimeters. I don't remember exactly. There is additional index. I do not use it a lot.
It's difficult. It means the negative of the
Negative T and depression of ST is ischemia.
And the microfocal.
Patient have hypertrophy of the right ventricle because of R waves are big and S waves are big too, and R equal to S in the lower leads in the V5. Due to hypertrophy of the right ventricle, patient feels ischemia. So patient can have an angina pectoris attack, but it's caused by hypertrophy of the right ventricle. Girls, guys, you can go. P waves are here. Rhythm is regular. Electrical axis. There is only one R wave in the first lead, so electrical axis is shifted to the left. Second lead, elevation of ST. Third lead, elevation of ST. Both leads have a QS waves. There are no R waves. Second and third lead have it, that's why AVF. AVF has the same signs. QS, elevation of ST. So this one is inferior wall. Transmural Myocardial Infarction. Stage is
Elevation, that means
this picture. This picture or not? QS plus elevation of ST. If ST is elevated, it's acute stage or initial one. If there is Q plus elevation, it is acute stage. So initial stage main criterion is ST or T changes. Acute stage, main criteria, Q wave plus elevation of ST. Subacute stage, Q wave plus negative T, ST close to isoelectric line. And last stage, reduction stage, Q without ischemic changes, without ST and T.
So Q without?
Without ST and T changes. So, another leads are normal. Quality. P waves. Rhythm is maybe regular, maybe irregular. It's more clear here. It's regular. Electrical axis. Only one R wave in the first lead. V2. Second lead. Q R small S wave. Elevation of ST doubled by phasic T. R small is written if R below isoelectric line. It is criterion of myocardial infarction too. Third lead, QS, elevation of ST, biphasic T. AVF, same. So it is acute transmural myocardial infarction of the inferior wall. Look at 1 and AVL. ST segment is depressed. And R waves are very big. If I will turn card like this, it will look like a QS elevation of ST, like we saw in the second and third leads. It's named concordant changes. Anterior wall register opposite ECG to inferior one. If inferior wall have a myocardial infarction, anterior wall will have turn card. Not always, but it is possible. So in the same way, we can suspect myocardial infarction in the posterior wall of heart. So these changes are because of inferior wall myocardial infarction, not because of anterior wall is affected too. Quality is okay. QS wave. T wave is absent. QS, T is negative. QS, T is negative. It is subacute transmural myocardial infarction. It's not reduction yet. T is negative. T is negative. It is subacute.
Positive, that's
Yeah. V1, V2, V3, and V4 have a QS, elevation of ST, big T. Acute transmural myocardial infarction of the anterior wall, septum, and apex. Quality is okay. P waves are here. Rhythm is regular. Electrical axis is shifted to the left. The Bidgestar wave is here. First lead, negative T. Second lead, everything look okay. Third lead is okay. AVL, negative T. AVF is okay. V1, QS, elevation of ST, maybe, but not enough. V2, QS, elevation of ST, double T, same. QS, ST close to isoelectric line, negative T, negative T, negative T. Come in.
Second year.
Yeah, it is fifth group. Wait. So, QS plus elevation of ST, it is acute myocardial infarction, transmural, because of our wave is absent. Anterior wall, septum, apex. And it starts to spread to lateral wall, because of there are negative T waves here. So ischemia is in the lateral wall too, but there is no necrosis yet. Let's take tachycardia. Last card. Quality is okay. P waves are here. Rhythm is regular, electrical axis is in the middle, so it's not shifted, it's normal. First lead, negative T. Second lead is okay. Third lead, everything is okay. AVL, negative T. AVF, everything is okay.
It's very close to the ST elevation.
Wait. Maybe depression of ST is here. But there are no elevations. Maybe depression, but not exactly. Let's turn this card. V1. What is this wave? No. There is very small R wave. Decreased amplitude of R wave is one of the criteria of myocardial infarction, but it's still initial stage because of R wave did not disappear fully. In some hours it will disappear and it will QS wave, but now it's still R wave. That's why it is R, S, elevation of ST, doublet T. R, S, elevation of ST, negative T, elevation of ST.
So there is no
Same. There is no Q wave yet. It will happen soon. But now our diagnosis is acute coronary syndrome. Next we prescribe troponine test. If troponine test is positive, it is initial stage of myocardial infarction. If troponine test is negative, it is angina pectoris. But in dynamic, 99% that this R wave will disappear and it will QS wave. After 1, 2, 3 hours it will happen with this patient. But your diagnosis is acute coronary syndrome with ST segment elevation. That's it.